Hello. I'm not sure if I can be seen. This is Gavin Morrison.
We can see you, Gavin.
You can see me. Oh, sorry, I couldn't see myself. Welcome, everybody. This is Gavin Morrison. I'm a pediatric ENT and an otologist from London.
Sorry, Gavin.
And it gives me great pleasure to be the chairman of this session 2, Cholesteatoma in children. We had a very interesting morning, and I'm welcome to everybody.
Sorry? We cannot see you, Gavin. Please put your video on. Thank you.
I tried to, so I beg your pardon.
Yes, good.
You can see me now?
Yes, good.
Oh, thank you, everybody. Apologies for the technical hitch from me there. So we've got a very nice panel, a very exciting panel. I'm just going to introduce them to you all. And then my friend and colleague, Françoise Denoy, will take us through some more of the sessions. So first of all, François Simon from the L'Hôpital Necker, Enfants Malades in Paris, and he also works at the Descartes University, is going to tell us about the consensus recommendation on congenital cholesteatoma from the International Pediatric Otolaryngology Group, of which he is a member. Then we're going to have Professor Adrian James. Adrian, as you know, is from the Hospital for Sick Children in Toronto. He's been a great contributor and publisher to our specialty over many years, and he's talking about otoendoscopy and cholesteatoma. We're going to then hear from Pedro Escada, Professor of Otolaryngology at the Hospital Egas Moniz in Lisbon. He has over 100 publications in peer-reviewed journals, and he's going to talk to us about canal wall down techniques. And we're then going to hear from Professor Thomas Somers. Thomas needs no real introduction. He's a giant in otology and also in pediatric otology. He's from Antwerp, St. Augustinus Hospital and the GZA hospitals. And he's the adjunct head of the European Institution for the ORL as well. So we're looking forward to hearing him tell us about mastoid obliteration techniques. And we may curtail the MRI aspect because we're going to have a little discussion with questions and answers on MRI surveillance straight after that meeting. And then at the very end, there's a video which Françoise is going to take us through and talk about questions. Please feel free to put your questions on the live Q&A, and we will pick up some of them in the discussion. So thank you very much, and we'd like to move straight to Françoise's talk now, please.
So hello, this is François Simon from Necker Hospital in Paris. I'm going to present to you the IPUG consensus on congenital cholesteatoma. So of course, you'll know what congenital cholesteatoma is, but just to remind you, so this is a typical photo here of a retrotympanic white mass that we can see very clearly with a normal eardrum and no history of any specific otological disease. It is quite rare. In the literature, we can find ranging between 5 to 10%, but rising. And for example, in our center, we're now reaching almost 25%, mostly due to a reduction of the number of acquired cholesteatoma. So the IPUG consensus was an opportunity to try and develop guidelines, or at least try and find consensus between leading pediatric otolaryngologists worldwide. It's of course a rare disease, so it's difficult to study it with conventional methodology. So we had 22 members who came from 14 different centers. So the idea of this study was through a Delphi method to try and determine from the 14 centers which were the what was the common ground. So the first thing concerning preoperative assessment was just based on otoscopy, of course, either microscope or telescope. But it's very important to determine which gradients are involved. We'll see about this a little later. Concerning assessments, of course, it's as any tympanoplasty, it's important to test audiometry, bone and air conduction in both ears before surgery. And concerning imagery, everybody agreed also that CT scan is mandatory. This is especially interesting concerning congenital cholesteatoma, as we can see here, because there isn't usually any ear disease elsewhere in the ear, so we can really clearly see where the cholesteatoma is on the imagery. MRI wasn't discussed in this case. It was only in very specific cases, in addition to CT scan. Concerning patient consent, there was consensus on these different things, which is also regular information to be given for any tympanoplasty. So, of course, information on the location of the incision, depending on the approach used, that it can be a dangerous surgery with ossicle removal and possibly hearing loss after the surgery. The usual risks: facial palsy, hearing loss, balance, and dural exposition. And of course, the possibility of a second look and long-term follow-up. So we'll talk about these two last points later on. The surgical technique was of limited consensus. We found that this was very variable according to the different teams. So here are three main things which stood out and which were consensual. Endoscopes weren't used only on their own by any of the teams in all cases. Of course, they might be used in very small cholesteatomas, but they weren't systematically used on their own, but they were always used at least with the microscope, especially to explore blind areas. Everybody agreed that in certain cases, it can be done to leave congenital cholesteatoma in place if it is dangerous for the patient, especially concerning stapes. So it is possible in some cases when the stapes is intact to leave it there, of course, you mustn't take it out. And if there is cholesteatoma which can't be taken off because it's really stuck to the stapes and you're going to take a risk to try and mobilize the stapes, then it's best to leave it in place and come back in a second revision procedure. Of course, everybody agreed that it's very important to try and keep the matrix intact as much as possible. Concerning eardrum reinforcement, so this is quite interesting. There wasn't a clear consensus, but you can see that the majority of teams chose to reinforce the eardrum if the cholesteatoma was larger than 2 quadrants. So you can see here the importance of the initial examination. And why is this? Is that, of course, it's not the same disease as acquired cholesteatoma. There's less risk of retraction pockets and so on. But if the surgery is large enough, we consider, and of course, if the cholesteatoma itself is large enough, that the eardrum can be thinner and might lead to retraction afterwards. So this is what most teams do, is that at least if it's over 2 quadrants to reinforce the tympanic membrane. Concerning bony canal reconstruction, in the first case here, this is when the surgeon destroyed part of the bony canal to be able to access the middle ear. In this case, you can see that there is quite a large proportion of people who did not reconstruct the bony canal. However, in this second case, where this is bony canal destruction due to the disease itself, in this case, everybody decided to reinforce the bony canal. Concerning ossiculoplasty techniques, so of course there are 2 main versions of this. Is where the stapes is missing or is present. So this is what was recommended by the teams. You can see that all teams, 14 out of 14 here, recommended ossicular replacement prosthesis when the stapes was missing. And we also asked them what they actually did in the past 5 years. And this reinforces this theory that all teams performed ossicular replacement prosthesis, and then some cartilage fragment and some the incus. When the stapes was present, same thing. all teams suggested that ossicular replacement prosthesis, so in this case, of course, partial, was a good solution. Cartilage fragment was much more used. And however, when we asked them what they'd actually been doing in the past 5 years, this also reinforced the ossicular replacement prosthesis. Cartilage seems to be, of course, a good solution. This is what we actually do in our center, but there are only 6 other centers like us, or 5 other centers who actually did this, and where the other ones preferred PORP. Concerning post-operative management, so this was quite consensual also. This isn't very specific to congenital cholesteatoma though. Off school was usually a short week. Whether there was ossiculoplasty or not, sport time could vary. Of course, if there was ossiculoplasty, no sport time was prolonged to 6 weeks, otherwise it was just under a month. And the swimming time also is about 6 weeks, which is the regular time for the first follow-up. Long-term follow-up now. So the basics, of course, here is the clinical follow-up, which everybody agreed had to be frequent the first year, so at 6 months, and then 6 months after that, 1 year, and then yearly. And here the really important message is, like in any cholesteatoma, is the prolonged follow-up. So the follow-up must be at least of 5 years, if not more, because we know in different studies that recurrence, either residual disease or retraction pockets, can appear in a really long time after the surgery. It can be fine for 3 or 4 years, and then you can have a problem arising 5 years afterwards. Concerning imagery, CT scan was considered not mandatory by almost all the teams. It can be asked for in specific cases, but this is very surgeon dependent. And it's mostly in cases where there's a change during clinical follow-up, either with audiometry or just on the aspect of the eardrum itself. And so in any case, it's not part of the usual follow-up if everything's fine. MRI was, of course, discussed. This is the usual imagery which is used for cholesteatoma follow-up. So here you've got, this was not consensual on how the MRI was actually used. So most teams agreed that 18 months was a good time to do the first MRI, because of course, if you do it too early, then you're not going to be able to see small pearls of cholesteatoma, residual cholesteatoma, which are 2 to 3 millimeters in diameter. You only see the pearls which are larger than that. So there's no really point in doing it too early. And many teams also said, this is what this is here for, that if the cholesteatoma was small and if it was taken out with an intact matrix, then it's also acceptable not to do a systematic MRI during the follow-up and just base your follow-up on the clinical and audiometry. Frequency and the long-term follow-up also was controversial. So everybody agreed that you had to repeat it, but the frequency, most of the teams said 2 years, but it could be every year or every 3 years. This was variable. And the follow-up also, this was discussed. It seemed most of the people said that it could be also as long as the clinical follow-up, so 5 years, but this varies also quite a lot from one team to the other. Some stopped 3 years, 4 years, this changed quite a lot. So thank you very much for your attention. This study has been published, and so you can find it online to read it. And I hope you have.
Thank you very much, François, for your talk. So I will now hand over to Adrian James. He's going to present his experience of autoendoscopy for cholesteatoma surgery. Thank you, Adrian.
François and the other organisers for the opportunity to speak at this virtual conference organised through ESPO. In the next 8 minutes, I'm going to try very quickly to go through 8 tips that I hope you'll find helpful if you're considering adopting totally endoscopic surgery on cholesteatoma in children. So the first thing to say is it works. Using an endoscope for cholesteatoma surgery helps to reduce the risk of residual cholesteatoma. That's been shown very clearly by this recent meta-analysis published by the group from Mass Eye and Ear in Boston. And when we do totally endoscopic ear surgery, that is, we use the endoscope to operate through the canal without an external incision, there's less morbidity, there's less pain, shorter hospital stay, faster recovery, less chance of wound complications, and so there are many good reasons to consider doing totally endoscopic surgery for cholesteatoma. The next thing to say is that it's possible in children. This photo shows Dave Pothier, one of the leaders of the International Working Group on Endoscopic Ear Surgery. He's seemingly here doing the impossible, climbing up this rock face. He moved to Toronto just over 10 years ago, and when
Κυρίες και κύριοι, γεια σας. Σήμερα έχουμε κοντά μας τον κύριο Μινά Αρτόπουλο, οριλά διευθυντή χειρουργικής τραχύλου και
everything through the narrow meatus of a child's ear. But since then, it turns out from experience that it's very possible to do it even in young children. This graph shows the proportion of children that have had totally endoscopic ear surgery according to age. So you can see it, roughly 75% of children at any age, it's possible to do cholesteatoma surgery endoscopically. And of course, we have to have a microscope available. If we find the cholesteatomas are extending beyond the midpoint of the lateral semicircular canal into the back of the mastoid antrum, then we're probably going to need to do a posterior approach and a mastoidectomy. For most of us, there's a very long learning curve. This slide here shows my learning curve since I started working at Sick Kids just over 15 years ago. And you can see for the first few years, although I was using an endoscope in all my cholesteatoma surgeries to check whether I'd left any disease behind, it wasn't until about 10 years ago that I started doing totally endoscopic surgery. And then over 5 years or so have built up to the final percentage of around 3/4 of kids being able to have their surgery totally endoscopically. And of course, that proportion is going to depend upon how extensive the disease is in your practice. If you have a lot of, if most of your disease extends into the mastoid, then there's less chance of doing the surgery totally endoscopically, but you can still use an endoscope through the ear canal to good effect for the middle ear component. There are several things that we can find helpful to get us up that learning curve, and the thing that made a big difference for me was getting 3mm endoscopes and suction dissectors. This is an example here of using of an angled suction dissector, and you can see how we can use it not just to suction the blood out of the way, but to retract at the same time as we dissect. I'll show dissecting on the anterior canal wall here. You see how much blood was welling up in this child's ear despite using hypotensive anesthesia to try and control things. Despite that large amount of bleeding, with a suction dissector, it's very possible to continue the surgery effectively. You'll see there's a note there not to use an endoscope holder, and you can certainly see while the surgery is being done, the endoscope is being moved continually in order to optimize the view and make space for the instrument according to where we're operating. Now, I was thinking that I'd put a slide up saying case selection, and that when you're starting, you might want to pick an easy case like this small congenital cholesteatoma in a 3.5-year-old, and certainly with the straight ear canal, and it's also a short ear canal at this age, endoscopic ear surgery is can be quite straightforward. But when I was looking at this video, it occurred to me that really this isn't a case that you let your trainee have their first attempt at. There's quite a lot of intricacy in working around an intact ossicular chain like this, and so there may be other cases that you might want to start on in which the ossicular chain is not intact, so that there's greater freedom of movement without risk of injury to the patient. Here, of course, you can see the dissection is concentrating on the root of this congenital cholesteatoma on the anterior surface of the processus cochleoformis. Some people would do more radical surgery and divide the ossicular chain and divide the tensor tympani tendon to get access, but you can see that's not really necessary. We have access to a KTP laser, which has the advantage of being flexible so that we can bend it slightly to get into tight corners like this. Here you can see the lasers being used to remove the remains of the tensor fold, the mucosal fold at the top of the supratuberal recess here, to which the cholesteatoma was attached, trying to make sure that there are no remnants of residual disease left behind. It is often not possible to predict preoperatively whether you'll be able to remove cholesteatoma totally endoscopically. In this case, the cholesteatoma had eroded the long process of incus, so the incus was removed, and it was found that the disease extended way back into the mastoid antrum. Now, I don't like making a bigger ossiculotomy than this because it can be difficult to provide a stable reconstruction, and so did my best to try and free this up, and sometimes the cholesteatoma is not firmly attached within the mastoid, so as in this case it can be possible to pull it out even through quite a small ossiculotomy. Looking in now with a 45-degree scope, you can see that the antrum is clear. So one of the most important tips though is that you might need to change tack. And you might find that you can't do what you wanted to do endoscopically. And I think it's very important to concentrate on the point that we measure success by a good outcome for the patient and not by saying, oh, I used an endoscope. So it's just a tool to help us. We use a microscope if needed. We use a postauricular incision if needed. But I would like to make the point that if you never try to do it totally endoscopically, you'll never be able to do it totally endoscopically. And it's only with patience, persistence, and perseverance that, with the knowledge that it's possible, that you will be able to accomplish a large part of your cholesteatoma practice with totally endoscopic surgery. So just to finish off, the final question, why do it? Why make the effort to learn how to do totally endoscopic cholesteatoma surgery? And the answer is patient preference. If you tell a patient that you can get equally good results by working through the ear canal or by making an incision behind their ear, what do you think they're going to choose? Of course, patients are going to prefer to have surgery without an external incision. If you do have to make a postauricular incision, my last plea is not to use interrupted sutures like somebody did on this child, but to use a
down techniques in pediatric cholesteatoma. Let me introduce myself. I'm Pedro Escada from Nova Medical School in Lisbon, Portugal. In my country, 13 institutions have ENT residency programs. My department is the one with the longest tradition of making. We will have the 48th edition of our temporal bone dissection course. The subject of my presentation can be looked at under the following headings. Which canal wall down techniques will be discussed? why these techniques have been used, why many surgeons avoid these techniques in children at all costs, when surgeons still choose, and when surgeons should avoid these techniques, and conclusion. Canal walls. For the purpose of this presentation, I will discuss only canal wall down techniques with these characteristics that we all know very well. Removal of the posterior and superior bony canal, removal of bone down to the vertical facial ridge, creation of a common cavity, ear canal and mastoid, and the making of a myoplasty. I will not discuss techniques that start as a canal wall down procedure for exposure and are modified to gain a canal wall up-like anatomy, such as reconstruction of the ear canal or obliteration. Before I move on, I'd like to recap why these techniques have been used, particularly in pediatric cholesteatoma. First, because pediatric cholesteatoma is aggressive and has a great risk of recidivism. Finally, because we believe that canal wall down techniques has a lower recidivism rate and can avoid subsequent surgeries. But we can ask now, if these techniques have these advantages, why many or most surgeons presently avoid them at all costs? Several reasons can be pointed. Functional results are hardly predictable in canal wall down procedures. The goal of obtaining a dry and complication-free ear sometimes is not achieved. Activities in the water can be limited, and the manipulation of a child's ear in the clinical is often very difficult. You can see here the experience of my department in the surgery of cholesteatoma in the last 5 years. In the pediatric group, only 15% of the surgeries, 4 cases, were canal wall down techniques. All these 4 surgeries were primary, no revisions, and the children had acquired primary cholesteatomas and a very contracted mastoid. 1 children had a complication, a labyrinthine fistula, and you can see also that a significant percentage of the pediatric cases were revisions, mainly planned second look procedures. This brings me to the question, when surgeons still select canal wall down techniques in pediatric cholesteatoma nowadays? These indications were obtained after a discussion with other Portuguese colleagues that perform pediatric ear surgery. We can name it. After multiple failed attempts with canal wall up techniques, in an only hearing ear, in ears with complications, in large labyrinthine fistulas when matrix cannot be resected, on very contracted mastoids, in children with poor general health with an anesthetic risk, and finally in children in whom follow-up will be problematic. Nevertheless, one can argue that even in some of these situations, we still can opt for a hybrid technique in order to avoid the disadvantage of a completely open cavity. As a final point, I like to draw your attention to this last question. Children with cholesteatoma, particularly of the congenital type, have mastoids with extensive pneumatization. These ears are not good candidates to canal wall down techniques that result in a long-standing unstable mastoid cavity in most cases. The first time I heard this advice given to me by Professor Michael Portman in one of his courses was in 1992 in Bordeaux. He explained that a simple X-ray of the ear could help in the decision between a closed technique and an open technique. Surely that nowadays we use the CT scan, but the advice is still valid. To conclude, I'd like to quote a well-known surgeon, Mercke, that in 1995 expressed that many different methods can be used in ear surgery, all correct. Thank you for your attention.
Thank you very much, Pedro, for this very good focus. And so let me introduce now Thomas Sommers, who is going to present mastoid obliteration techniques. Thomas, it's to you. So Thomas is going to share his screen and do a live presentation.
Can you see my presentation?
Yes, very good.
Okay, I'm going to talk about acquired cholesteatoma, not about congenital cholesteatoma, and when do we and how do we perform obliteration technique, and how do we, well, we can discuss this later about this screening with MRI. The eternal question, of course, is whether you are going to use a canal wall down or a canal also, it has already been stated that the hearing results might be less favorable. On the other hand, you have the canal wall up technique, where you leave the posterior wall in place and you go from the mastoid and through the canal. This leaves you with a better hygienic situation at the end with a self-cleaning ear, and in theory, functional results should be better. But there is also a but here. In the past, often a second look surgery was needed because we couldn't see what was going on, certainly behind the posterior wall, and residual pathology could be left behind. And this was the case before we started to obliterate in 24% of the children's population. In children, again, the possibility of recurrent pathology was also high. And so there was also this need for long-term follow-up, which has also already been mentioned. Surely 5, but I would say even 10, even not, and even better is more than 20 years, even lifelong follow-up. But this eternal question of canal wall down and canal wall up is probably going to move and might change into and become an obsolete debate, because the real issue today might be when to obliterate or not. And if you see what we are achieving at the end is exactly the same. Whether you are departing from a canal wall up technique or a canal wall down technique, what you're achieving at the end is a new ear canal again. So it depends a bit on your training, how you have been trained in the past or your background, that you will go from an open technique to achieve this more closed situation after obliteration. We think that the problems of residuals and recurrence pathologies have been solved to a great extent thanks to the canal wall-up and mainly by the obliteration of the paratympanic spaces. And we have seen less residuals, 4 times less and 6 times less recurrences than before. This means 1997. Our experience dates back to 1997 when we started to use this technique, so more than 20 years. The non-EPI diffusion weighted MRI has been supporting this theory and this technique because it allows us to look for residual pathology to see what's going behind this posterior wall, and it avoids second look operations. We didn't invent the technique. It was all popularized by Ulf Mercke in Sweden. Sweden is not only the IKEA country, but also the Bony obliteration inventors. And here you see a cholesteatoma. He used to remove the posterior wall with a Feldman saw just to have a better control, which then followed by an obliteration and putting back this posterior wall, palva flap in red and a bone pate in orange. We modified this technique by leaving this posterior wall in place. We don't remove it. He temporarily removes it. But at the end, we will close off the attic and the posterior tympanotomy windows very, very safely with bone chips and then close it further off with bone pate. So the intervention, quickly retroauricular incision, collecting bone pate with the bone collector. Bone pate is retrieved here, mixed with rifampicin. Then eradication of the cholesteatoma is performed, leaving the posterior wall in place, eradicate the cholesteatoma as well as you can. So this is the final stage. And you have these windows which need to be closed off by bony chips. You can use other materials, but we use bone, and bony chips are retrieved from the mastoid edge. Mastoidectomy edge. So it's a very important and most difficult step of the operation. You should take your time when you're doing this and make sure that you have a very, very safe closure of this cavity. So herefore we use the curved bone chips. We need a very sharp chisel, which is beveled on one side. You dig into the bone and then you will slowly, but you will then retrieve this curved chip of bone and insert it neatly here in this window, in the posterior tympanotomy window. And those should be eventually overlayered in 2-3 layers. They should fit snugly. And if any gaps are still there, bone cement or hydroxyapatite cement could be used. So you see here a result. Then the bony obliteration is performed with the bone pate soaked in the antibiotic solution, composite cartilage graft, cartilage with perichondrium is then inserted, and a PORP or a TORP can be used. Also in the past we used allografts, but nowadays I use more cartilage, under which a PORP or a TORP can be introduced. All kinds of ossiculoplasty techniques can be used, either with an ossicle or a titanium prosthesis, or even cement, but that's done all during the same procedure. Here you see the results before and after. What did we achieve? If we see without obliteration, the residual rate was still high, certainly in the pediatric population, 24%, and did drop down to about 6% after we used the obliteration technique. So that's 4 times less. So also because we use MRI nowadays, we don't or recurrent pathology. So here recurrent pathology was high in those 90s. Nowadays it's only 2 to 3%, and no cavities are performed anymore. So 4 times less residuals, 6 times less recurrences. Hearing results haven't really changed dramatically. So in 50% of the cases, the hearing remains the same. It improves, it improves in 50%. It's maintained to the same level with obliteration, 50%, 25% when you don't obliterate, and it deteriorates a bit more after obliteration than without obliteration. But on the average, statistically speaking, it's not statistically significantly different. So we have mainly three situations, but I don't want to go too much into detail about that, but just speak a little more about the small cholesteatomas where we don't obliterate completely, because you will perform what we call a partial obliteration. Here you see that I looked at the series of 38 cases of very small attic cholesteatomas, and there doing only a partial closure with this bone chip here, where behind we put the bone pate, but leaving the attic space intact, we will have recurrences in 2%, residuals in 16%. So today we don't use any second look surgery anymore, but we use non-EPI diffusion weighted imaging. If positive, we will do the safe, dry, and water resistant ear. No cavities, no need for second look, but non-EPI at 1, 3, 5 years, and hearing results are similar to those after canal roll-up without obliteration. Thank you, François.
Very good, Thomas, all the time, and very good presentation. Thank you. So maybe Gavin, you could now begin the discussion about MRI.
Yes, thank you. Am I seen, and can you hear me?
Yes.
Thank you. Yes, excellent presentations, all of them. I wanted to focus this discussion quickly on the discussion of diffusion-weighted MRI and second look and who does what. I'm going to ask the panelists. I'd like to ask Thomas Somers, if he is going to do MRI for surveillance, is his normal time scale?
Okay, my normal time scale is 1, 3, and 5 years after surgery. So the first baseline MRI is done after 1 year, a second one after 3 years, and a third one after 5 years. If it's negative at 5 years, you could eventually do another one 5 years later, but usually the pathology has been totally removed. So if there is intermediate signal, sometimes you can see an intermediate signal, not a very white one, then I would do mean that you're dealing with a cholesteatoma. With intermediate,
So I agree. We sometimes get these reports back with proteinaceous secretions and some other imaging that is uncertain, and the radiologist says repeat, and we repeat it a year. Do you find that if there's a true cholesteatoma, it always becomes apparent when you have the second MRI scan?
If you have a small cholesteatoma, it will always become apparent. If you leave some...
Yes, it will.
Yes.
Okay. Thank you very much. So I'm going to ask Pedro.
Yes,
Pedro,
I'm there.
Are you there?
Yes.
Pedro, I want to ask you a question in 2 parts. Do you use an MRI scan
Yep.
Do you always use an MRI scan? No, always is the question.
No, definitely not. We've had a disappointing experience with MRI here, having having as much false positive and false negative as we have true positives. My concern is that once the disease has grown big enough to show up on an MRI, it's potentially become more difficult to remove. And this is particularly concerning if the disease is growing in proximity. There's a risk that the stapes will have become eroded before the disease is big enough to show up on an MRI. So I think that second stage surgery has, almost 100% sensitivity and specificity. And so my usual recommendation when I have concern about residual diseases is to do a second.
I'm going to come back to second stage quickly.
Can I say just something about MRI and the first MRI? In the consensus, Francois will maybe say that again, but people do it at about 18 months, and I think it's better because it has been shown in the literature that at 1 year after the cholesteatoma, false negative is about 40%. It's very, very high. So it's our experience in neck care, and I think 18 months is better because if it's negative at 1 year, third year you may have a very big residual cholesteatoma. So I am on the position of Adrian. We do second look procedure, and we do the first MRI if needed at 18 months and not 1 year.
Thank you, Francois. I agree with that exactly, the 18 months. Can I ask Francois, our first speaker, to tell me if is there a difference in his decision making about MRI according to how easy the surgery was? If he has breached the matrix, or if he thinks he might not have removed all the disease, or where the location of the disease was in the ear, are these factors that affect him at all?
In the delay of the first MRI, or in the decision to make
in doing an MRI rather than a second look. So you might say, oh, I think I left some disease. I'm just going to look again next year.
Well, certainly, if the cholesteatoma was anything else than a very small cholesteatoma with there would be an MRI in any case during the follow-up. What we usually do is, as Professor Denoyel said, is that we almost always do a second look procedure, except in very limited cholesteatomas. And we actually usually perform imagery before, so that's before the second look procedure. And then in the follow-up, we always do MRI, especially if a second look was undertaken.
Thank you. I must be quick, but I want to go back to Thomas Somers, please.
Yes.
Thomas, you've said you always use MRI and you have a protocol 1, 2, and 5 years. What happens if you do a canal wall up or down operation with obliteration, and you have a very bad hearing result, and you still have 50 decibel conductive deafness after your first operation, and the patient wants to hear well? Are you going to waste the resource of doing an MRI scan, or just reopen the ear in a year's time or 6 months' time to reconstruct the hearing?
I think I was surprised by Adrian's statement to do a systematic second look. Whereas nowadays with MRI, the sensitivity and specificity we reach is above 96%. So why to do all these operations, second look operations? I think we have to get rid of those second look operations. I think there are so many second look operations that have been done for nothing. Nowadays, you should be able to rely on MRI because a cholesteatoma will not kill a child. An anesthesia could kill a child, yes, to put can kill a child, but not a cholesteatoma. So I would not be in favor of doing all these surgeries and go and speak to your radiologist to try to improve the technique of the radiology. But then if you talk about not hearing well, I would not do an MRI. I would do a CT scan to see whether the ventilation is good. If there is no ventilation, no proper ventilation, then it's probably not even worthwhile doing a second operation for functional reason, because you do this second operation not for removing cholesteatoma. So what we first would do is MRI to check for a residual pathology, and a CT scan for seeing whether we can, or there is a chance we can improve hearing. If it's fully scarred, then we will probably not do a second look.
Thank you, Thomas. Thank you so much. So I think I'm running out of time now, and so I'm going to close this bit, and we're going to go to Françoise Denoy is going to show us a video, I think. Thank you.
Well, that's a short video to show removal of congenital cholesteatoma with a microscope, classic surgery. So you see here the medical history with an underroll approach, minimal underroll approach. And the tympanomeatal flap is elevated. We enter the middle ear cavity. And of course, with two hands, quite easy to do it. And then in this case, we made a dislocation of the incus stapes joint because the cholesteatoma was very big in the two superior quadrants. And the first thing of the procedure is to separate the tympanic membrane from the matrix of the cholesteatoma and the malleus. And then the debulking of the cholesteatoma is very important to facilitate removal when the cholesteatoma is big. And if you don't debulk, it's very difficult to separate properly the matrix medially to the cholesteatoma. So here we had to remove the heads of the ossicle, of the malleus and incus, and control at the end in the attic. So tracheal cartilage has been used because we have more than one quadrant involved by the cholesteatoma. It's our procedure, it's our protocol in Mercke. And then we had a cartilage block on the stapes to have a good hearing. And it's a cartilage block, we think it's very interesting in very young children because they can do all the sports they want, and we have never displacement of the ossiculoplasty. Thank you. So maybe we can move to the questions and answer. We have some questions from the audience, and one of the questions has disappeared, and the question was